Welcome to your most favorite channel, Heartbeat. My name is Dr. Kejriwal. This channel is mainly meant for MBBS students, postgraduates, medical professionals, and all those who may find it a bit more easy. It is an attempt to make the complicated medical sciences more simplified and easier for understanding.
Today we learn something about arterial blood gases. Channel's name is Heartbeat. My name is Dr. Kejriwal. Now this is just a model of the circulation simplified with the alveolus. So this is the dead space where no gaseous exchange occurs. This is the alveoli showing the arterial and venous circulation. This red block shows the left side of the heart, and here's the arteries, capillaries, veins, and the right side of the heart is represented by this blue block. Air comes in and out of the alveoli, occupying the dead space and alveoli, and let us see the difference in concentration of the inspired and expired gases. In the inspired air, the partial pressure of oxygen is 158 millimeters of mercury. In the expired gas, it is 116. Carbon dioxide in the inspired is 0.3. Expired air, it is 32. Water pressure is 5.7 in the inspired air. Expired air is 47. And in nitrogen, in the inspired air is 596 and 565. So this oxygen concentration varies from the 158 to 116 millimeters of mercury, and this is achieved in the capillaries predominantly. And just let us have a look how the partial pressure of these variables vary throughout the circulation. So when we go to the alveoli, the partial pressure of oxygen decreases from 158 to 100, and that of the carbon dioxide increases to 40. Water also increases to 47, and nitrogen decreases from 596 to 573. So we can see that there is a major decrease in oxygen and increase in carbon dioxide and water. This water accounts for the insensible water loss through respiration, and this oxygen again increases. So this oxygen mixes with the dead space area over here. So the oxygen concentration and the expired gas partial pressure increases. Similarly, that of carbon dioxide, since the inspired air is having 0.3 and carbon dioxide in the alveoli is 40, it comes to in the expired air, the partial pressure comes down to 32. Now, just see how it goes, the partial pressure of the various gases in the arteries. So, from oxygen comes down from 100 to 95, carbon dioxide remains at 40, water decreases from 47 to 47 maintains, and nitrogen from 573 to 573. So water and nitrogen remain the same. There is some mixing of the arterial and venous blood over here in the alveoli and again in the left side of the heart, so it decreases the oxygen concentration in the 90 to 95 millimeters of mercury. In the capillaries, in the venous circulation side, the oxygen decreases to 40, carbon dioxide increases to 46, and water remains at 47 and nitrogen at 573. So there is a major decrease in oxygen and increase in carbon dioxide. And in the venous circulation, it remains the same as in the capillaries, but when we go from the venous to the alveoli, the oxygen concentration increases, carbon dioxide decreases, water and nitrogen remain the same. This gives an understanding of the arterial blood gases variation throughout the circulation and inspired and expired gas. Now, types of acid-base disorder. There are some in which the pH increases greater than 7.4 and in some in which the pH decreases below 7.4, of which we are mainly concerned. So whenever the pH increases greater than 7.4, it is called can be due to metabolic alkalosis or respiratory alkalosis. And whenever the pH decreases below 7.4, it can be due to metabolic acidosis or respiratory acidosis. Arterial blood gases seem to be very complicated when we see them. They can be single acid base disorder, they can be double acid base disorder, or they can be mixed acid base disorder. Whenever an ABG comes, please note down the name of the patient, date when it was done, time, temperature at which was recorded, and usually they mention the machine also. There are various parameters that are given on the arterial blood gases. These are the measured pH, PaSO2, PO2, sodium, potassium, calcium, glucose, lactate, and hematocrit. These parameters are derived: calcium, bicarbonate, total CO2, base excess effective, base excess buffer, saturation of O2, and total HBC. In this lecture, we will be just discussing the pH, PaSO2, PO2, bicarb, and mentioning saturation. pH. Normal pH is 7.35 to 7.45. There is intracellular with extracellular chemical buffering which maintains the pH 7.35 to 7.45. Kidneys and lungs both are complementary. Coming to the Henderson-Hasselbalch equation, pH is equal to 6.1 plus log bicarb divided by 0.0301 into partial pressure of carbon dioxide in the arterial blood. So from this equation we can understand that whenever bicarb increases or the PCO2 decreases, the pH will increase and it represents alkalosis. And whenever the bicarb decreases or the PCO2 increases, the pH decreases, and this is called acidosis. Coming to PaCO2. Normal PaCO2 is 40 millimeters of mercury. Production is equal to excretion, and PCO2 gives us information of ventilation status. So under excretion of carbon dioxide means hypercapnia, and over excretion means hypocapnia. Production and excretion get matched at a new level. Increase or decrease of PCO2 can be due to various factors, either decrease or increased neural respiratory drive or in response to alterations of bicarb. PO2. PO2 relates to the partial pressure of oxygen in arterial blood, oxygenation status. At PO2 100 ml of mercury, hemoglobin is 100% saturated. At PO2 60 milliliters of mercury, hemoglobin is greater than 90% of saturation. Coming to the approach, check the pH. If it is less than 7.35, it is acidosis, and if it is greater than 7.45, it is alkalosis. Check the PCO2 and bicarb. If pH is less than 7.4 and PCO2 is greater than 40 milliliters of mercury, then it goes in favor of respiratory acidosis. And if the pH is greater than 7.4 and PCO2 is less than 40, it goes in favor of respiratory alkalosis. Coming to respiratory acidosis, if PCO2 is increased, check bicarb. In acute cases, bicarb should increase by 0.1 millimole per millimeter increase of PCO2. So in the arterial blood gases, the normal PCO2 is around 40 millimeters of mercury. So if it increases by 10, that is 50 millimeters of mercury, in acute cases the bicarb should increase by 1. And if it's a chronic case, the bicarb should increase by 0.4 millimeters increase of PCO2. So if the PCO2 increases from 40 to 50 in chronic cases, the bicarb should increase by 4 millimoles. If it is not, then it's another disorder exists. Respiratory alkalosis. If PCO2 is decreased, check bicarb. In acute cases, bicarb should decrease by 0.2 millimole per millimeter of mercury decrease of PCO2. So if PCO2 decreases from 40 to 30, so bicarb should decrease by 2. Normal bicarb is around 24. And in chronic cases, bicarb should decrease by 4.4 millimoles per decrease of PCO2. So if this PCO2 decreases by 10, bicarb should decrease by 40. So from 40, if the PCO2 comes down to 30, the bicarb should come down around somewhere around 20. If it may be less or it may be more, then it means that another disorder exists. Metabolic acidosis. Check bicarb, it should be decreased with a decreased pH. Now we have to see whether the carbon dioxide is compensated completely or not. So we've got various formulas. PCO2 should be equal to either 1.5 into bicarb plus 8 plus minus 2. So this will give you the exact value of PCO2. If it is same equal, then perhaps it's properly compensated. Or bicarb will decrease by 1.25 per millimole per decrease in bicarb. Or PCO2 is equal to bicarb plus 15. This is the most easiest to remember. If there is any variation in this, then another disorder exists. Metabolic alkalosis. HCO3 will be increased and PCO2 will increase by 0.5 millimeters per mole per increase in bicarb. So if this is not there, then another disorder exists. Or again, PCO2 is equal to bicarb plus 15 in metabolic disorders. If it does not present, then another disorder exists. Mixed acid base. When the values of PCO2 and bicarb do not move in tandem with each other, then another disorder exists. And this requires analysis of the anion gap. Anion gap is to be adjusted for serum albumin equal to 4.5 grams per deciliter. So examples of mixed acid base disorders are diabetic ketoacidosis with sepsis with renal failure, or poisoning with multiple medications, or diabetic ketoacidosis with respiratory failure with vomiting. So in these, the ABGs, carbon dioxide and bicarb will not move in tandem, and it can be seen when we analyze the ABGs. Coming to the anion gap. Anion gap is equal to sodium minus bicarb plus chloride. Bicarb and chloride both are taken together, and the sodium is subtracted. Normal value is 6 to 12 millimoles per liter. Increased anion gap is due to increase in unmeasured anions, occasionally due to decrease in unmeasured cations such as calcium, magnesium and potassium. Decreased anion gap is due to an increase in unmeasured cations, abnormal cations such as lithium, cationic immunoglobulins such as plasma cell dyscrasias, or hypoalbuminemia. And hyperviscosity and severe hyperlipidemia can also cause decreased anion gap. Every decrease in serum albumin by 1 gram per deciliter add 2.5 millimoles to the anion gap. So you will get the right. For example, for normal albumin is 4.5 and measured albumin is 2.5. So there is a decrease in albumin by 2 grams per deciliter, and if your anion gap is 10, then you will have to add 5 millimoles to the anion gap. Increased anion gap significant even if the pH and bicarb is normal. In organic sulfates and phosphates, they contribute. Organic keto acids, lactates, etc., they also contribute. Exogenous salicylates can also contribute, or unknown anions can also contribute. Now many times when we do the ABGs, we get a normal pH, normal PCO2 and normal bicarb, but patient is having symptoms of abnormal mental. Now just think of a condition in which a patient has a metabolic acidosis or plus metabolic alkalosis. Due to the acidosis, he will have a normal pH, normal PCO2 will come because of the metabolic alkalosis, and normal bicarb. And again, a condition in which a patient has metabolic acidosis plus chronic respiratory acidosis, the pH may be low, but normal PCO2 and normal bicarb will be there. So it becomes very difficult to interpret such arterial blood gases, and in such patients that is the anion gap that gives the clue.